Hello, everyone. Welcome to today's session. My name is Leslie Verner, and I'm Director of Programming for Carolina Breast Friends. We are so glad that you can join us today, and we are excited about having Dr. Justin Favaro with us. He is with Oncology Physicians of Charlotte, and he was recently recognized in the Charlotte magazine as a top doctor in hematology and oncology. And he's going to speak with us today on new treatments for metastatic breast cancer. So Dr. Favaro, thank you so much for being with us, and we are very interested in what you have to share with us today.
Thank you. No, it's great to be here. I always love talking to patients and advocates for breast cancer. This is an exciting time. I got an opportunity today to see two patients with metastatic breast cancer and to go through with them some of these newer treatments that are available. It gives us all so much hope, for better options for treatment that are better tolerated. So I'm excited to share what is out there, what's new, what's driving this hope. And I'm gonna go ahead and start sharing my slides now if I can. And I'm gonna apologize for being late. I've said that about 20 times today. I've been late all day, but hopefully we'll stay on time here. Let's see. Okay, everybody can see that? All right. I hope I can.
Yes, that looks great.
Okay, good. All right, and it advances this way. Advance the slides.
I don't know if I'm muted or not.
Okay, all right. Sorry, I went the wrong way here. All right, so today I'll talk about advances in cancer treatment for metastatic breast cancer, but I'll be happy to answer any questions you have about anything, any topics at all at the end. I've left plenty of time for questions. So my practice was founded in the year 2000 by James Boyd, Grant Taylor, Jeff Chapman. There were three great oncologists who came together to start our practice in the Eastover area of Charlotte. I joined in 2006, and we also opened up a South Charlotte office a few years later. So two locations. My background is I went to medical school and did PhD research as well. My research was in HIV viral replication. You would think that has no applicability to what I do today, but surprisingly it does, because there's so much molecular biology of cancer that we use that technology in developing new treatments. It helps me to understand and explain kind of what's going on with the biology of the cancer, how we take advantage of that for treatment options. So I finished my training at Duke in 2006. I've served as a principal investigator for many clinical trials. One thing I'll talk about at the end, after we talk about all this exciting data, is just advocacy for the healthcare system, and specifically for oncology, and how I'd like to challenge all of you to help us get involved with that. And I know you're already very motivated. And so today I'll talk about just about some of the history of the breast cancer treatment, again, focusing really on metastatic breast cancer treatment, some great news on survival data, and then talk about some of the advances in the treatment for cancer, going through all the different types, HER2 amplified, estrogen receptor positive, triple negative, just talking about some of the newer treatments, and then talk more about what cancer care is like here in Charlotte, and some of the challenges we face, really from the financial standpoint, and how we can all kind of do our part to get to learn more about that and to be involved as advocates. And I've been to Washington, D.C. several times, along with Sherry Bradshaw, who's our liaison, who's on the call today as well. And we've brought patients up there to talk and have those that are on treatment actually talk to our representatives, and it makes a tremendous impact on how they think about these issues. All right, so breast cancer evolution, there's records actually of breast cancer being treated before Christ, and 1800s actually was the first mastectomy done by Halsted. There's been many modifications to that procedure for that surgery. You can see here the timeline of using less radical breast conserving surgery and with radiation, showing that there's no difference in survival compared to the older mastectomies. In terms of endocrine therapy, tamoxifen was first introduced in the 1980s. In the 1990s, we developed the aromatase inhibitors, which we use routinely now for postmenopausal patients as anti-estrogen therapy. I'll talk a little bit more about the history of Herceptin, which came about in the 1990s. And as you can see, this graph here shows survival, the number of deaths from breast cancer. And you can see the number of deaths going down and down as we make more advances. And I start my addition to this in 2011. And I'll talk about many of these drugs, but in 2011, Progetta came along, which also attacks the HER2 positive breast cancer. Lynparza, which is for is a PARP inhibitor for BRCA1 and 2 mutations. Kadcyla, which is a re-engineered Herceptin with a chemotherapy payload. Ibrance, 2019, we had Tecentriq and Piqray, and then some new drugs in 2020, which we'll discuss as well. And the cool part about it is looking at the continued improvement in the mortality rates or death rates from breast cancer, going from 2000 to 2018. You can see we've gotten below 20 per 100,000 here in 2018. And so this is extremely encouraging to see these advances, prolong lives, and really better quality of life on treatment. And this is for females here. For men, it's held pretty steady. I think it's hard to get. I'm hoping that for men, we also see improvement, but it's hard because there's so few men in the data set. So how do these treatments work? And I don't want to get bogged down with too many slides and technical, but I do want to just maybe it would help just to kind of hear more about how all these drugs work. And all these drugs down here, the antibiotics, all these 4 categories really represent chemotherapy. The bottom line is they interfere with the replication of the DNA, interfere with cell division. So it affects many different types of cells in your body, not just the cancer cells, but the cells that are dividing most quickly are the cancer cells, so it affects them as well. Hormone inhibitors, so basically estrogen comes in, somehow that either reduce estrogen in the body or block the effects of estrogen on the cells, and that reduces the growth of the breast cancer cells. And we'll also talk a lot about monoclonal antibodies. These are basically smart bombs, and they specifically target the cancer cells, and that helps to kill the cancer cells or block them from growing. So you have the chemotherapy down here, which are kind of the dirty bombs, and then you have hormone inhibitors and monoclonal antibodies or smart bombs. We also have some pills that send smart bombs into the cell to stop the cancer cell from growing and kill the cell as well. So the different types of breast cancer, the 2 most common types are lobular breast cancer and invasive ductal breast cancer. In addition, there's rarely inflammatory breast cancer. Subdivide those into the hormone receptor positive, which are the majority, the HER2 positive, which are about 20%, the triple negative about 15%. And it continues to get a little bit more complicated looking at specific mutations. And so we're going to talk about PIK3CA mutation found in some hormone receptor positive breast cancers and how that affects treatment choices. And then PD-L1 positive. And so that is a marker for susceptibility for triple negative cancer, susceptibility to immunotherapy. And so we use that as well. So we've gone from, from just very general classification to more specific. And then I'll add in there genetic testing, BRCA1, 2, ATM check, PALB2. These are the most common inherited mutations that can predispose to breast cancer, and those, the presence or absence of those also affects treatment. The development of Herceptin was quite a story in the 1990s. Dennis Slayman is the physician scientist who did the initial trials using this drug in patients. Barbara Bradfield was one of the, I think she may have been the first patient that took Herceptin. She's doing quite well today. And then Harry Connick Jr. Was able to play Dr. Slayman in this movie Living Proof. Lucky to Dr. Slayman that he was able to be played by Harry Connick Jr. But it's a great story of, you know, learning about the biology of the cancer, developing a drug, and seeing dramatic improvements in outcomes and survival. So, so what is Herceptin? Herceptin is a smart bomb. It's a monoclonal antibody. It's a protein that comes in here and attaches to the outside of the cancer cell, and that allows the cancer cell to die, stops the cancer cell from growing. Developments with Perjeta that we talked about is another type of smart bomb that hits the Herceptin receptor in a different way. And so what we found here in 2015 or so was that the combination of chemotherapy plus Herceptin and Perjeta frontline in patients that have HER2-positive metastatic breast cancer improved survival by 16 months compared to this Taxotere and Herceptin. So the focus here is that the addition of this one drug, Perjeta, improved survival by 16 months in these patients. That's a dramatic improvement. And I'm going to show you another a statement here that we're going to come back to later, but I just wanted to kind of show this to you. And this is a comment about Perjeta, the use of Perjeta in metastatic breast cancer patients. And it was a study done and published in Journal of Clinical Oncology 2015. And they basically looked at the cost. And they said the cost of this drug for quality of life year gain is basically the cost of 1 year of Perjeta was $700,000. And this person who is basically somebody who does cost analysis on the cost benefit of drugs, said that it was unlikely to provide reasonable value for the money spent in the United States compared to other interventions. And I mean, that was, in my mind, a very disturbing thing to hear and to see in one of our medical journals. Is a statement that basically putting a cost on the year of life and saying it was not a reasonable value for money spent. I strongly disagree with that. I've seen patients on this drug do well and have an extra year of life, and I think this is kind of the danger of what I would call centralized control of healthcare. And I hope that gets you a little interested in healthcare policy. We'll talk more about that at the end. But Perjeta really is just an amazing drug, done miracles for patients. This is the same model I showed you before, and the next steps have been to attach chemotherapy to these drugs. Okay, so instead of just having a smart bomb, you have a smart bomb that's loaded with another bomb, and so it comes into the cancer cell, it attaches, and actually it's brought into the cancer cell and releases this chemotherapy, and it allows for more effective treatment by doing that. And so it's a combination of a smart bomb and the dirty bomb attached to the molecule. So one example of that is a drug called Enhertu. This is one of the new 2020 drugs, and basically it is a Herceptin drug, Herceptin monoclonal antibody with the chemotherapy attached. It attaches to the HER2-positive breast cancer cell and is brought into the cell. Okay, it's brought in and releases the payload, which is chemotherapy, and that causes the cell to die. And what the studies have shown were that after you've had Herceptin, after you've had Perjeta, if you take this drug Enhertu, it provides benefit. The tumor is going to get smaller. The typical progression-free survival is over a year on this medication. That's a long time. It's similar to what we saw with Perjeta. So another great advance, another year of life with a new drug. It can cause interstitial pneumonitis. I just put the most common, important, I should say, side effect that we have to look out for with this new medication that was recently approved. Another weapon against HER2 amplified breast cancer is Tukysa. This is a pill, and it sends this pill is a very small molecule. It goes inside the cell membrane and attacks the Herceptin receptor from the inside of the cell. And the studies with this drug show that with combination with Herceptin and Xeloda, there was improvement in survival by adding this medication. And interestingly, because it's so small, it can get into the brain. So somebody with brain mets, it provides stability of the brain mets for about 5 months. So that's another advance, an advantage of this compared to other medications. And I showed some of the side effects of hand-foot syndrome and diarrhea. So you can see how all this research into the biology of these cells has paid off dividends with the development of these new drugs. And so you're just basically stacking the treatments on top of another. You start with Herceptin, Perjeta, Taxotere, you move to another treatment, and continue to do well for longer term. And so just in summary, the typical first line treatment is the chemotherapy, Taxotere, Herceptin, Perjeta. After that, we can go to Kadcyla, which is another loaded monoclonal antibody, or the oral pill. And HER2 is this new drug can go 2/3. After that is chemotherapy plus Herceptin. And remember that in the mix, we sometimes will add anti-estrogen therapy or the PARP inhibitors if appropriate. All right, so next I'm going to talk about the hormone receptor positive breast cancer, the most common type. And so these breast cancer cells tend to be dependent on estrogen to grow. And so we first started out with tamoxifen, and then we came along the aromatase inhibitors, letrozole, anastrozole, exemestane, and these basically reduce production of estrogen in the body. So you're taking that estrogen away, taking out that growth stimulus for the breast cancer cells. And the research with Ibrance came along. And Ibrance is a pill that works somewhat like Tukysa, in that it's a small molecule, gets inside the cell and prevents the growth of the cancer cell by a different mechanism. And so we found that the combination of these two drugs, the letrozole to stop the estrogen, the Ibrance by blocking growth signals inside the cancer cell, led to longer disease-free survival for patients, and a pretty well-tolerated medication. So the class of these drugs with Ibrance are called CDK4/6 inhibitors. And there's 3 different brands. Ibrance and Kisqali are taken with aromatase inhibitors. Verzenio can be taken either by itself or with aromatase inhibitors. And in addition, they can also be taken not just with those drugs, but also they can be taken with Faslodex. And in premenopausal women, they can be taken in combination with ovarian suppression. The data is pretty amazing. Without adding a lot of toxicity, especially when you talk about the Ibrance, we doubled the progression-free survival from 1 to 2 years. When you look at Ibrance itself, the major side effect is neutropenia, and that's pretty manageable. It doesn't usually cause fever. You have to hold the treatment and let the counts recover. But in general, people feel pretty well on that medication. There may be a few other side effects, but that's what I usually use up front because of the tolerability is Ibrance plus an aromatase inhibitor or another form of ovarian suppression, whatever is appropriate for that situation. Another drug is called Piqray. I've seen commercials for Piqray. And what we look for is when we initially diagnose hormone receptor positive breast cancer, we look for the PIK3CA mutation. And this mutation is found in about 40% of patients. And it basically stimulates growth of the cancer cells. And so now we've developed a drug called Piqray, which inhibits that particular mutated protein and causes the cell to die. And so this drug, Piqray, in combination with Faslodex, which is an injectable anti-estrogen drug, improved survival. It doubled progression-free survival by 6 months. It can cause severe diabetes, and if any of you have ever been on this medication, you may know that. Almost everybody gets high blood sugars on it, so that has to be carefully managed. So just to summarize where we are with hormone receptor positive metastatic breast cancer, suppress the estrogen, whatever the appropriate way, usually an anastrozole or letrozole for postmenopausal women, plus a CDK4/6 inhibitor, Ibrance. And that usually is a good combination for about 2 years. And if that stops working, then you can move on to Faslodex, which is an injectable anti-estrogen, plus Piqray, if that's appropriate, if you have the appropriate mutation. If not, we can combine that medication with Afinitor, which is a different inhibitor that we've had on the market now for about 5 years. And so what that allows us to do is to keep you off chemo. You start with the hormone therapy and these other oral medications. They do have side effects, but it's also better quality of life. And if we've progressed through all those things, then we do move on to chemotherapy, and there's multiple options that you can see there. And we just try to go from one drug to the next. And I always put down here about the PARP inhibitors, which I'll talk about in a few minutes. So this is interesting. This just came out. This is a non-metastatic information, but I want you to make aware of it since it just came out over the weekend. We've been testing the CDK4/6 inhibitors in the adjuvant setting in women that have hormone receptor positive breast cancer. These are high risk cases that are either large tumors or with node positive disease. You go through surgery, radiation, and chemotherapy if appropriate. Okay, and this study shows that adding 2 years of Verzenio to the anti-estrogen therapy improves outcomes. And so the disease-free survival is significantly improved. And so that will, I'm sure, become standard of care almost immediately for those situations. So this slide's a little bit off topic, but it is extremely new information that just came out. And I'm sure you all follow the data and the research. You have the big breast cancer meeting in San Antonio. It comes at this in December every year. And then we have the ASCO meeting in June. And this data just came out of ESMO, which is the European Society meeting, which is currently going on or I think just finished. So I'm going to move on to triple negative breast cancer, and I'm going to start by talking about immunotherapy and trying to explain to you how all this works and what the how the immunotherapy drugs work. So in a cancer patient, the immune system is turned down. And the cancer cells do this. They have these receptors here that on the tumor that touch the immune cells and turn them off, okay? And so for years, research has been going on trying to see how we can turn these immune system cells back on to fight the cancer. And so eventually these drugs were developed that will block this interaction here. So it blocks a turnoff signal. So now these immune cells are angry and they go after the cancer. And so that's essentially how these drugs work. And when I was doing fellowship at Duke, a lot of people were doing research on this, but it was to no avail. We didn't have very good drugs that could do this. And now, since over the last 7 or 8 years, it all started with melanoma, and it's moved into multiple other cancer types, including breast cancer, triple negative, which I'll talk about. And so this is just another diagram of how the immune system works, how these immune drugs work. And this particular trial looked at patients who have triple negative breast cancer, newly diagnosed, and they get chemotherapy alone versus chemotherapy plus this immunotherapy drug called Tecentriq. And it showed an improvement in overall survival by 10 months. And that's really specifically for patients that express the PD-L1 antibody. Okay, so that's not all triple negative breast cancer, but those that express the marker that allows for this drug to work, you get a significant improvement in survival. It can cause skin rash, diarrhea, pneumonitis. We use, in my practice, I use these drugs all the time for so many different types of cancer. We're very familiar with how to deal with them in terms of their side effects. And the good news about side effects with this drug is they can be reversed with steroids. Steroids turns the immune system off. So if you got a bad problem, you just go start on steroids and things get better, as long as we catch it quickly. Another smart bomb with chemotherapy attached called Trodelvy. Trodelvy is a monoclonal antibody here that has chemotherapy attached, and it's specific for triple-negative breast cancer cells. So it attaches to the cell, goes inside, and causes disruption, leading to the cell dying. And this new drug has been shown to have improvement in 34% of cancer patients, and the median duration of improvement of their disease was 9 months. And so if you're one of the 3 out of 10 that it works for 9 months. It does cause neutropenia, so we have to be careful for that. But again, another option, another weapon in our arsenal to treat this disease. And so just to summarize for triple negative, what we do is we look at the PD-L1 positivity as a marker to see if immunotherapy will work. If it's positive, immunotherapy may work, and so we start off with that. And if that works, great. If it doesn't, we try chemotherapy, and then we have this new drug, Trodelvy. If it doesn't have the positive marker, then we use different types of chemotherapy and Trodelvy. And of course, Lynparza, which is the most common PARP inhibitor for BRCA1/2 mutations. So while the bottom line is we've made progress, we've got more to make, but there's now new drugs, and many of which are don't have as many side effects as chemotherapy. So these PARP inhibitors are specifically drugs that are really only to be used in patients that have an inherited BRCA1 or 2 mutation. So what happens is when somebody gets chemotherapy, there are damage occurs to the DNA, and there are proteins in the body in the cell called PARP proteins, and they repair the damage. But when you have a PARP inhibitor, then these proteins don't work and the damage doesn't get repaired. The DNA breaks up and the cell dies. The reason PARP inhibitors work so well in patients that have a BRCA1 or BRCA2 mutation is because if you have that mutation, you have a hard time repairing DNA break to begin with. So if you add this drug, it really causes a lot more damage to the DNA inside the cancer cells. So that's why PARP inhibitors are really, at this point anyways, for BRCA1/2 mutation, but we're looking at other types as well. The 2 FDA-approved drugs for breast cancer, one is Lynparza and one is Talzenna. And then this is experimental, but this is looking at the combination of a PARP inhibitor concurrent with chemotherapy, and then continuing the PARP inhibitor afterwards. And that data looks pretty promising. We don't have an FDA approval on that yet. Excuse me 1 second. So the summary of just what we talked about, I mean, great news on survival, great news on these new drugs, which I'm excited to use, and I know you guys are excited to have them. We talked about the HER2 positive. This Tukysa is the pill that gets inside the cell, can also interrupt brain metastasis from growing. And then this HER2, which is the smart bomb loaded with chemotherapy. And the hormone receptor positive, the new PIK3CA inhibitor, Piqray, and then this new data that came out over the weekend from ESMO using this drug, the CDK4/6 inhibitors, in combination with anti-estrogen therapy in the adjuvant setting. And in triple negative, it's immunotherapy, it's in HER2, a loaded monoclonal antibody, just really exciting times. And so just to finish off, I wanted to talk a little bit about what we do at my practice. Everything we talked about, we do. And one of the things we focus on is using supportive care. And so all this standard supportive care with medications, but also we have a machine called DigniCaps, which prevents hair loss during treatment. And so we really, use cutting edge care. We use all the state-of-the-art for supportive care. Some of the genetic testing we talked about is also done in our clinic, and including work with clinical trials. And so I think, as a cancer patient, you have so many great options here in Charlotte for treatment. It's good to know that wherever you go, you're going to get great care. I wanted to talk a little bit about the state of cancer care in Charlotte as well. We talk about the two hospital systems a lot, but there's also a nice network of independent oncology practices in Charlotte. And Southern Oncology Specialist is up in the north market, and then my practice is here in Eastover and also in South Charlotte, and then Carolina Blood and Cancer in the Rock Hill, Lancaster area. And I think we offer a little bit of a different take on treatment in that we give the standard of care, the cutting edge care, clinical trials, but it's in a smaller setting. And so I think that has a real advantage in terms of convenience, in terms of personal touch to the care we offer. And these are a lot of the people that work at our office, our Christmas party. Everybody's very happy when they come to work, and that's really what's so important, I think, for the experience. These are our treatment rooms. We have an outdoor deck, and this is a DigniCap machine, which I mentioned, which we have in both offices actually to help prevent hair loss, and it's done a wonder. I mean, it's you guys go through it and you see and you experience it, and I think there's benefit to not losing your hair if it's something you want to do. We've been here 20 years, and we're excited to continue providing care. We do a lot of advocacy in my practice. This is the Hope for Hair Foundation. In February, I gave a keynote speech just talking about the changes in patients' perspective when they don't lose their hair. And there's a foundation to help pay for the machine, which isn't always covered with insurance, although they're getting better with that. We go to different races. This is a brain tumor race. We've done the Komen race for the cure as well. I'm one of the pink tie guys here in town. I think this is a great organization, which we haven't been involved with. I'd love to be more involved in the future. And I also gave a talk at the Rotary Club in February talking about what we do and how we deliver care as an independent practice in Charlotte. And there's a lot of discussion about the cost of care, and nobody feels that burden more than those going through treatment. And one of the major controversies is how the hospital consolidation that's happened in Charlotte and other areas of the country has increased the cost of care. And all this consolidation means that many of the physicians are employed into large networks. And so, there's a concern there about central control of the physicians and their decision-making power. In addition, that those large networks really hold a lot of leverage over the insurance company. And so the contracts basically just have an increasing cost of care from the insurance company paid to the hospitals for the delivery of services. And so that's something we like to discuss in our advocacy organizations. And I wanted to bring this up again just to talk a little bit about the healthcare policy. I talked about this, the cost of pertuzumab and for 1 year and how that was discussed as unlikely to provide reasonable value for money spent. Well, I strongly disagree. I know many of you would as well. The other issue is about universal healthcare or socialized medicine. And they've done many different studies looking at what survival looks like in our country from breast cancer, for example, compared to other countries. And this particular study came out in 2017, looked at the 5-year survival rate of breast cancer. And these are just comparing different countries that are well developed, have thought to have good healthcare systems around the world. So the United States was the winner. Australia and Canada were second. And the United Kingdom, which had a survival rate of 80%. So you see the difference of 89% in America, 87% in Canada, 80% 5-year survival in the United Kingdom. And so the reasons for this are access to care. They're good doctors there, they're really caring, but they don't have access to all these drugs I talked about today. If they gave a talk like I did today, their talk would be much shorter because their government doesn't pay for these new drugs as soon as they come out, so their patients don't get access to them. In addition, because there's fewer resources It takes longer to get in to see your doctor, which basically delays diagnosis and treatment. And the type of services we provide at our practice, we would like to let more people know about that. We have a program called Sit in My Chair. We bring local leaders or national leaders into our practice. They sit down, they get their blood drawn in a pretend way, and they sit in a chair where other patients are getting chemotherapy. They kind of see what the experience is like. They see what some of the barriers are that we currently have in our system. And I think this is a great way to educate people about what you as patients go through. And the other thing that I think that makes us very unique is we want you to be involved as well. There's an organization called CPAN, it's COA Patient Advocacy Network. It's basically came out of this parent organization, Community Oncology Alliance. And this is a national organization across the country, and it represents independent oncology practices. And we had our first event in Charlotte, the first event in Charlotte for patients a few years ago. And you're welcome to, we had patients come into our office. We talked about the healthcare policy and how that affects cancer patients. My interest is in decentralizing healthcare and putting the physicians and the patients in charge. And I think that really allows for better access to care at a more reasonable cost to the system, but still great quality care at a very personal level. And so we educate patients about this. And this organization also brings physicians and patients up to Capitol Hill. Before COVID, we had an annual meeting in Washington, and I'm sure those will resume as well. So you don't have to be a patient in my practice to be involved in this. And so I know you're recording this and you have Sherry Bradshaw's email, and that's our office phone number as well. Please email or call us, and we'll put you on a list so that when we have our next meeting, we can invite you and learn more about all these factors that you hear in the news that so dramatically affect cancer care in our country. So I do appreciate your attention today. I'd love to answer any questions you have about the medical or healthcare policy side of my talk today. Thank you for your time.
Thank you, Dr. Favaro. That was a wonderful presentation, and your slides were excellent. It was great to hear about all the new drugs that are available for patients with metastatic breast cancer.
Thank you. It's exciting. It's exciting to talk about them too.
It really is, and they just keep coming out with new ones. It's just wonderful. It's prolonging the lives of so many women. We have one question in the chat so far, and that could definitely change. But it is from Sandra Goldman, and she was first diagnosed with stage 2 breast cancer in 2010, and then in 2016 for a second time with cancer in the pec muscle, and a third time in 2018 with it in the pec, and now also in the deltoid. She is considered metastatic, and she has done genetic testing twice in 2010 and 2015. She does not carry any known mutations, nor is she BRCA positive. She's simply estrogen positive. She knows that many gene mutations are known now since her last testing. Would it make sense to do another round of genetic testing to figure out any reason why? Let me just, it's a little hard to move this question down. To figure out any reason why she got cancer in the first place, and to figure out what meds to take. She's currently on Ibrance and fulvestrant.
Yeah, that's a good question. The genetic testing is evolving. I would say every 5 years it's reasonable to do it again. There are new mutations that we didn't know about before. What happens when we send genetic testing off, they may find mutations that aren't known to be significant, but they may be in the future, bearing some uncertain significance, we call them. And so when you get it tested, then you get in a database, and then if those mutations become significant or known risk factors for cancer, they call you back and let you know that. And so I don't know from the 2015 testing you had if that is something that they would do, or to be safer, just go and get retested And that way, if there's anything that's come out over the last 5 years, you'd know about it. Would that change any of your management? If there was a BRCA1 or 2 mutation that wasn't known 5 years ago that is known now, that is significant, then it could allow for the ability to use PARP inhibitors. There are other mutations as well besides BRCA1 and 2, like ATM, like PALB2, and some others. And so we see those other ones too. We know their risk factors. We know they can be inherited. And so if you had another one, it wouldn't allow us to use PARP inhibitors, at least not right now, but there's research on that. But it also would also be able for you to tell your family members that they need to be tested, because those other markers, besides BRCA1 and 2, are markers for increased risk and would allow them to get screened earlier. It could save their life.
Okay, we also have a question from Kathy Goodman. She said, great presentation, exciting to know that new drugs are available to help our survivors. And she is asking, what is HFS? Is it a side effect?
Oh, right, that was abbreviation. So that was called hand-foot syndrome. You know, and certain drugs like Xeloda and Tukysa, even the combination, can basically cause where your hands and your feet get red and irritated or dry. And that's something that needs to be managed. And so we look out for it. If you're on those drugs, just moisturize with a urea-based cream 2 or 3 times a day. Moisturize them really well and put gloves and socks on when you go to bed. That way you can kind of keep the moisture locked into the skin in those areas. For whatever reason, because of high friction, I think they're more susceptible to irritation when you're on, and really the drugs are Xeloda and Tukysa that will cause that.
Okay, and she also would like to know, how long do you give a new drug time to respond in a patient before you move to another drug?
Yeah, so what we usually do is we start it, if they're tolerating it well, then we usually give it for 2 months and then repeat the scans. I may repeat if there's a good tumor marker in the blood, then I may repeat the tumor marker after 1 month, but usually 2 months and then repeat the scans to make sure things are working.
Okay. Libby Meadows would like to know, do you have clinical trials available for metastatic triple negative, PD-L1 negative, and are you familiar with the clinical trial carboplatin and ribastanib?
Yeah, there's a lot of clinical trials out there. Unfortunately, in our practice, we don't right now. I'm not familiar with that one, just to be honest. I think that going through the standard treatment that I talked about, and if those, I would usually start off with those, but if there's complications or they're not working, I definitely advocate for a clinical trial to look at these new drugs coming out. I think the chances of a clinical trial working are much better than they used to be, because we're just getting better at developing drugs that are effective. So, so I think clinical trial is a great option.
Okay. And Charlene would like to know, are there other lines of defense once progression is experienced with the PARP inhibitor Lynparza in BRCA patients? Anything in the pipeline?
There definitely are. New PARP inhibitors are being looked at all the time. There may be something there. We often will go back to chemotherapy in that setting as well. But one of the things I've seen when I've been to the national meetings are combinations of immunotherapy and PARP inhibitors. And there's a lot of emerging data that those two may work well together. So keep your eye out for that, because I think that may be an effective combination.
That sounds very promising. Those are all the questions that we have right now. If anyone emails me, Dr. Favaro, would it be all right if I forwarded that to Sherry and,
yes, please.
and ask you to answer it, in the, oh, let's see here. Okay, I do have one more. Do you have another minute to answer another question?
Sure. Time in the world.
All right. Oops, let me get to it again. Okay, it takes just a second to get the question in the right place in this chat box. Okay, this is from a survivor with metastatic breast cancer. She was diagnosed with mets to the liver in 2013 after chemo, no radiation and surgery. After chemo and no radiation and surgery, there was no sign of disease in her body. She continued with Herceptin and tamoxifen. In 2016, she had a recurrence with another round of chemo. After chemo, no more evidence of disease. She was taken off the tamoxifen. They kept her on the Herceptin, added Perjeta along with the Arimidex.
Okay.
So now she's taken Herceptin, Perjeta, and Arimidex.
Yeah. Good. Yeah.
And so do you think there's anything else she needs to be taking in addition to that?
I think that's a great combination. I mean, it seems to be a well-tolerated combination. You get an echo of your heart every 3 months. I would watch the tumor markers. I would get scans. If you always want to know if your tumor markers are good markers. Were they elevated when your cancer was not well controlled, so you know that it will go back up again if things change. So if you have a marker in your blood that's a good tumor marker that we know is a good reliable marker of your disease, I would stick with what you're doing and get those markers every 1 or 2 months to make sure they're stable. If the markers go up, then I would get some more scans. You could just get scans every 6 months or so just to take a look at that as well. But hopefully if you have a marker that's good, you can continue doing blood markers and stay on the aromatase inhibitor and the Herceptin Perjeta. I think it's a good combination. And you just have to keep in mind too that if things change down the road and you need a different treatment, if that's no longer working, well, I mean, you've got this other drug, Tukysa, with Xeloda and Herceptin. That's another, that newly diagnosed drug, the newly developed drug that I talked about. And the advantage of that one is it goes into the brain. So there may be some protective benefit to your brain for that drug. So if you got that as an option, you got Enhertu as your next line, the new loaded monoclonal antibody. So that's another option down the road. And you always have chemotherapy, which we really, I mean, there's multiple chemotherapy drugs you can combine with Herceptin. So the blockade of the HER2 continues. You just keep changing out the other drugs for something different. And that's how you control this disease. And so it's great. I think you're doing very well. I think that's a good treatment for you. I would think that at this point, your quality of life should be pretty good with that treatment.
And she's also asking, she was told that she would have to stay on this or something else for the rest of her life. Do you agree with that as well?
Yeah, I think with your history, I would stay on it. I think you need to have your cancer suppressed. I think there's evidence, I believe in what you told me, that it had come back before in the liver. So I would stay on it.
What?
As long as yeah, right. So as long as your echo is good every 3 months, I would stay on it. And there are people on those drugs for years and years. I mean, even decades. There are patients that have been on those drugs for over 10 years, doing quite well.
Okay.
Yeah.
It is so wonderful to hear that we have all these different options now.
Yeah.
I've been a breast cancer nurse for a long time, and this is I don't remember another time when we've had so many options for metastatic breast cancer as we have right now. Ren is asking, go ahead.
No, so I hope they keep coming. You know, I think that the key to keeping these drugs coming is keeping our system healthy. We've got to have a healthy pharmaceutical industry, a healthy healthcare industry, because that's where the pipeline starts, right? So I'm really hopeful that will continue down the road. I think it will. It's an exciting time for a physician. It really is, and that's why I include the healthcare policy at the end, because I think that's kind of the engine behind the pipeline, is making sure that we have a healthy healthcare system. And what I mean by that is where physicians and patients are in control, not hospitals, not bureaucrats, not insurance companies. I mean, there's too much control from insurance companies. We need to take the data and sit down and have a conversation and start the right treatment for you. And that's the delivery part that has to be optimized as well. So you have the pipeline part from all the companies, and then the delivery And that's where we just need to optimize those things. So I think it's great. It's great and it's exciting, and I want to keep it going.
I totally agree. Ren would like to know if Trodelvy stops working, would you recommend moving her to Enhertu?
Well, Trodelvy. Okay, so so what kind of do you have a triple negative breast cancer, or do you have a HER2 positive?
Ren, you can unmute yourself to answer that question. I don't know if she's on right now, so I can't answer that question off the top of my head.
Yeah,
Triple negative.
Oh, triple
Oh, there
negative.
she
Okay.
is.
Yes.
Sorry, triple negative. Yeah. So then HER2 is really for the HER2 positive cases. So I think after this current treatment you're on, it really depends on your history, what you've had before, if you have a BRCA mutation or not, to look at your different options. But it's more weighted on chemotherapy and the triple negative side.
Okay, thank you.
He was also asking, would you suggest moving to Trodelvy once Abraxane and Tacrotric, I don't know how to pronounce that one, stop
Tecentriq.
working? Yes.
Right. Yes. So I think that's a good option. So I think that's a good option to do. You could certainly do that. I believe you go back to my slides here. I'll do that. Sure. I think I have to go back and look. Let me check one thing here.
Okay.
Yeah, it looks like you've had at least 2 prior treatments before you can go to that new drug. So, so the Trodelvy requires 2 prior treatment options. So if you came in and you had Abraxane and Tecentriq first, there's your first option. If that didn't work, you have to go to chemotherapy, and then you can go to Trodelvy as your third option.
Okay, we now have several questions. People have had time to type into the chat box. So you just tell me if you need to go, okay?
I'm good.
Okay, great. Charmaine is asking again, she was the one I talked about just a minute ago with the 2 recurrences, and she's on the Herceptin, the Perjeta, and the Arimidex. She wanted to know if you've heard of a case similar to hers. She has good markers with no evidence of disease in her body, and she does have scans every 6 months.
Yeah, I do. We've seen it. We've taken care of the cases like that. We currently are, and so that's part of the amazing story of Herceptin. I showed the picture of that patient. And, the time that Herceptin was developed, she started on it, and she's doing well now. I don't know if she's still on Herceptin, but we definitely have cases of those being on Herceptin for over a decade. And then Herceptin Perjeta and the aromatase inhibitor, it's a good combination because you're using Herceptin Perjeta to attack the HER2 receptor in different ways, and then you're adding in the anti-estrogen therapy, and so you're really attacking the cancer in 3 different ways. And I would just stay on it based on your history, as long as your heart's doing okay. We do have other patients that have been on Herceptin for 10 years or longer.
Okay. Dar Finkelstein would like to let everyone know that there is a Charlotte area metastatic breast cancer support group that is currently meeting virtually. And she also wanted to thank you so much for today's presentation.
You're welcome.
excuse me, if anyone would like to know more about that support group, please email me and I will put you in touch with Dar. Tammy Griffith is asking, what are you looking for in respect to healthcare policy activity?
Well, I think first is having another meeting. We'll bring in a speaker, a national speaker, and basically, number one is education. What kind of healthcare policies are going on in Washington? How do those affect the cost of cancer, every cancer treatment, your access to different doctors? And so it's just an educational thing to begin with, and it's education for me as well. It's hard to keep up with all the medical and all the healthcare policy. But that's number one, and we do it at our office. And then after that, then you would be part. You can even join the group now. You can get on the website and join the group now. You don't have to wait for us to have a meeting. We'll probably do it virtually. So, but that's kind of how you get educated and learn about it. And then, once COVID's over and it's safe to travel, if you're continue to be motivated, you can travel to Washington, or you can be in communication with your local representative and, learning about the issues and then communicating that over to the politicians. And they need to hear from us. They need to learn what it's like to go through cancer treatment and learn what barriers there are. They depend on that in order to do the right thing for us. So I think it's a great thing where you're teaching them and educating them. So the organization can educate you, and you can learn about the issues, and you can ask good questions, and then based on what you've learned, based on the policy ideas, you can take that back to your representative.
Sandra Goldman would like to know, let's see, just a minute. I have to go back up on my chat here. Do independent oncologists here in Charlotte collaborate with the two other big hospital systems?
Yes, we do, all the time. And so it really depends on where you want to get your care, how you want it delivered, and where you feel most comfortable. We offer a care that's convenient, it's quick, I think it's a very efficient care, great standard of care. But I think it's important to have other people involved in your care as well. I trained at Duke. I know great doctors at Duke, UNC, Wake Forest, Levine Cancer Center. And so we can work as a team. You can always go and get other opinions and other thoughts, and we can work together. But so that part really works well. I have good cordial relationships with them. I have privileges at both hospital systems, and so I'm involved in their tumor boards and as well at both hospitals.
That sounds terrific. She's also asking, she's been just under a year on Ibrance and fulvestrant. Cancer marker has gone up and the scans show some light ups. She's trying to stay as long as possible on these meds, but will get to the point probably sometime soon where she'll need to change drugs. What would you suggest for the next drug regimen after Ibrance and fulvestrant?
Fulvestrant. Okay, yeah. So after that, I would look at either a blood test or a biopsy to look for the PIK3CA mutation, and that's about in 40% of cases. So if you have that mutation, then we would move over to the PIK3 medication. That's typically combined with anti-estrogen. So in that case, I would consider actually combining that with an aromatase inhibitor. Now, if you don't have that mutation, then the next line of therapy would be an aromatase inhibitor in combination with Afinitor, which is basically that's an mTOR inhibitor. It's a very similar, it's a targeted therapy, much like PIK3 and Ibrance. It targets a different molecule. And so that would be, either one of those two would be your next line of treatment.
Okay. It looks like we have one more question. I'm almost there. This chat box is a little super sensitive as far as moving the mouse. If I move it the wrong way, it completely goes haywire. I'm almost there. She's asking if you can repeat the mutation, and it's the PIK-RA mutation. I can email you about that, Sandra.
Yeah. You can do a blood test for it or biopsy of the rebiopsy of a growing tumor. I think the blood test would be a lot easier if you can get it that way.
That's great. Well, thank you so much. This has been an amazing presentation.
Thank you. I really enjoyed it. Love to come back and be
We
more
would love
involved.
to have you back.
Please, everybody,
Thank you
welcome
so
to
much.
join us as well. Thank you.
Thank you for your time and your expertise. It was a pleasure.
Thank you so much. Have a nice day. Night. Appreciate it.